Welcome to the presentation. We're talking today about cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. This is really a procedure that's reserved for a clinical condition called peritoneal carcinomatosis, which really means there's implantation of tumor cells throughout the peritoneal cavity. This condition is frequently seen with certain malignancies, including colorectal cancer, cancer of the appendix, gastric cancer, primary peritoneal carcinoma, mesothelioma, sarcoma, and ovarian cancer. If you look at the different type of malignancy, appendiceal cancer, mesothelioma, and ovarian cancer are probably the most common to present with isolated peritoneal carcinomatosis. Other types can present with carcinomatosis, but frequently will have also liver metastasis. Now, if you look at try to understand the pathophysiology about why peritoneal carcinomatosis occur, it's really related to a couple of physiological factors. One is related to the flow of the fluid within the peritoneal cavity, which tend to occur in a clockwise fashion, and this is really governed by the gravity along with the movement of the diaphragm during breathing, as well as the peristalsis or movement of the intestine. The omentum, which is a layer of fat that covers the intestine, also has some phagocytic activity that helps eradicate some of these cancer cells. And therefore, the most common sites where we would see this for implantation in the abdomen tends to occur in the omentum, under the right hemidiaphragm, that's where the liver is, also in the pelvis, and non-visceral peritoneum, that's the lining of the abdominal wall of the peritoneal cavity. You see here, this is some examples of what carcinomatosis look like. If you look at the upper left corner of the screen, this is actually a shot of the pelvic. This is a shot of the peritoneum resected from under the diaphragm, and you can see here, this is actually the tumor implantation, as you can see, implanted on the diaphragm, which otherwise normally would look kind of smooth, as you see in the picture down below. On the bottom left of the screen, this is another picture of the peritoneum. This was over the pelvis, and again, you see here tumor implantation. You can see there are actually multiple tumor sites. On the upper right corner, this is a picture of the omentum, as you can see here, and literally is replaced by tumor implantation, as you can see here. This is omentum attached to the colon, which is right down here. Down in the bottom right, this is actually tumor completely replacing the ovary. You can see here in both ovaries in the pelvis in a female patient. So this is really tends to be the most common site where peritoneal carcinomatosis would occur. How do we find about peritoneal carcinomatosis? Quite frequently, it's found at the time of laparotomy in a patient who is known to have a GI malignancy, and that tends to occur in colorectal cancer, stomach cancer, also in pancreatic cancer, ovarian cancer. Or sometimes we find this at the time of planned appendectomy. A patient comes in with a diagnosis of appendicitis. The patient is taken to the operating room, and at the time of the operation, we found that they have carcinomatosis. Patient who presents with massive ascites, where the abdominal cavity is filled with fluid that's secreted by this tumor, and also times of bowel obstruction, that we also suspect carcinomatosis, because this is fluid that's secreted by tumor cells. Or if a patient has a known history of colon cancer or ovarian cancer, and their tumor markers, which is the CEA level in colon cancer and the CA-125 in ovarian cancer, they are rising, and there's no clear evidence of malignancy, then carcinomatosis is probably suspected and is present in the patient. The clinical issues with peritoneal carcinomatosis of interest to you as a patient is that frequently the tumor burden or the amount of tumor that's present before the patient becomes symptomatic is quite large, and that creates some difficulty in management and treating this condition. Early diagnosis of small volume carcinomatosis is rarely possible, and I'm going to show you some imaging study and to tell you how it's very difficult to visualize this tumor in imaging study, which are relatively insensitive to the early diagnosis of carcinomatosis. Even when we see evidence of carcinomatosis on imaging study like a CAT scan, the X-ray tend to significantly be accurate underestimate the extent of the disease because, again, it's not visible on the imaging study. One of the things that we try to educate patients, physician alike, is that there is this traditional assumption that condition is incurable, untreatable is not really the case, especially with the advancement of surgical technique and the new therapeutic agents. Certainly, patient with carcinomatosis should consider cytoreductive surgery and hyperthermic intraperitoneal chemotherapy as a really viable and valuable option for the treatment. This is an example of how imaging study underestimate the extent of the disease. This is a picture here of a patient with carcinomatosis, and you can see this little spots or white dots on the mesentery of the colon. You can see throughout the mesentery of the colon. You can appreciate why it will not be seen on the CAT scan, which really cannot tell us much if the tumors are less than centimeter, but this is an example of how the disease can be mistakenly not seen on imaging study. This is another example on when we suspect carcinomatosis. On the bottom right, you can see a picture of the CT scan, and right here you can see what's suggestive of what we call omental caking, and this is the actual patient after the surgery. You can see again what we see in the CAT scan really corresponds to extensive carcinomatosis replacing the omentum and involving loop of small bowel. This is what we see again here in another patient. You see the CAT scan pictures on the right and the actual specimen after surgery, and you can see the extent of the disease. You see on the CAT scan, you see omental caking right here. There's obviously ascites right here on this side, and this is actually what the specimen, surgical specimen, looks like, and you can see the extent of disease. In fact, on the far bottom right, this is an image of a CAT scan of the same patient about a month after the surgery. You can see that the tumor and the ascites has completely gone away after the treatment. But one of the reasons we do the imaging studies also is to exclude reasons why not to operate. I think patient selection is important for good outcome. We certainly look for extra-abdominal disease. So a patient who comes in with abdominal carcinomatosis, but also have skeletal metastasis or lung mets, certainly we don't consider this patient for this extensive procedure. A patient who comes with the obstruction of the bile duct and they are jaundiced, it's very, very unlikely that we will be able to eradicate the tumor just because of the proximity of important structures and blood vessels that does not allow us to proceed with complete cytoreduction. Multiple sites of bowel obstruction tends to be a problem because they will require extensive bowel resection, and quite frequently we are unable to complete the cytoreduction. So this is just some of the general conditions that might preclude us from considering cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. Now, if you look at the value and the goals from cytoreductive surgery, really summarized in three conditions. One is obviously to maximize tumor debulking and potential effectiveness of the chemotherapy we utilize. That's really the main thing we want to do. Obviously, we would like to minimize toxicity and postoperative complications. This surgery can be quite lengthy and quite extensive. And certainly, our utmost benefit from this is to improve survival, but also the quality of life of the patient undergoing the procedure. So, had to achieve all this goals from the surgery, we have to develop an operative strategy. And this is, if you would discuss surgery, the cytoreductive surgery with your surgeon, then this is what you need to be aware of. What are the goals from surgery? Well, we know for sure that complete removal of the omentum is routine, because that's where one of the most common side of the disease. When involved with peritoneal lining over both the hemidiaphragm, right and left paracolic gutters, this is the peritoneum next to the colon, and in the pelvis, we need to remove all this involved with disease, and frequently in women, that were also involved doing a total abdominal hysterectomy with bilateral salpingo or oophorectomy. We will take the spleen out when it's involved by tumor, or in the hilum of the spleen there is tumor implants. We frequently would have to take the spleen out. And then for tumors that are in the mesentery of the bowel or in the surface when they are diffuse and extensive, we certainly cannot resect the whole bowel. So we would do what we call thermal ablation or electroevaporation of tumor. Essentially what we do is we turn the heat on using the electrocautery in very high cut setting, and then we really burn this tumor. We try to minimize bowel resection as much as possible. It's not infrequent occurrence that the patient would require an ostomy, which can be temporary or also can be permanent depending on the extent of the disease and involvement of the rectum. So once all the tumor has been debulked, we then would proceed with hyperthermic intraperitoneal chemotherapy, which is delivered via perfusion circuit. Now, what this allows us is to deliver a very high concentration of chemotherapy in the peritoneal cavity with minimal systemic exposure because the drug is delivered locally in the peritoneal cavity. It does not get absorbed in the blood, so this systemic toxicity potential is very, very small. And the major drug that we use for cytoreductive surgery and hypothermic intraperitoneal therapy is a drug called the mitomycin C. It's usually the drug of choice. Other chemotherapeutic agents are also available, and we use them according to the histological type of the carcinomatosis. This is a schematic presentation of the circuit. You'll see that at the time of the perfusion, we put inflow and outflow catheters. This can range from 1 or 2 inflow catheter and similar for the outflow catheters, and it's connected to a perfusion circuit, which is needed to deliver the heated perfusion and the chemotherapy within the circuit that allows to perfuse the peritoneal cavity and circulate. And usually we do that for about 90 minutes while the patient is asleep under anesthesia at the time of the surgical procedure. The temperature is maintained between 39 and 42 degrees Celsius. The reason is for that high temperature is cancer cells are more heat sensitive than normal cells in hypoxic environment. So that leads to actually increased tissue penetration of the chemotherapy and also potentiate its effectiveness. So that's the reason why we use the hyperthermia associated with the chemotherapy. If you look at the outcomes of cytoreductive surgery and HIPEC in terms of hospital stay, the mean length in the intensive care unit ranges from 1 to 5 days. Hospital stays ranges anywhere between 7 to 48 days. And the overall mortality, the chance of a patient dying from this procedure ranges from 0.9% to approximately 5.8%. And the major reason a patient would suffer an adverse outcome from this operation is usually related to infection and multi-system organ failure as a result of a surgical complication. This is not much different from major GI cancer operation, so it's really not significantly increased. Morbidity ranges anywhere between 12 to 52%, and the reoperative lead is anywhere between 0 to 23%, and usually related to bleeding or an stomatic leak or infection within the abdominal cavity that needs to be explored and operated upon to promote recovery and healing of the patient. If you look at specifically for colorectal cancer and appendiceal cancer, because this is one of the most common conditions, we would perform cytoreductive surgery and HIPEC. If you look at appendiceal carcinoma, there are several clinical conditions. First one, by far most known to patients, is the pseudomyxoma peritoni, or disseminated peritoneal adenomyosinosis, known as DPAM, or peritoneal mucinous adenocarcinoma, or the adenocarcinoma, which is more so in the colorectal carcinoma. The previous 3 histological subtypes are more common in the appendiceal carcinoma. If you look at specifically for colorectal carcinoma, we know that about 10 to 15% of patients with colorectal cancer will have peritoneal carcinomatosis at the time of initial diagnosis. It will occur in as many as 50% of patients with recurrence, and up to 25% in patients it's the only site of recurrence. So you can see that there is a fair number of patients who, with colorectal carcinoma, who will develop only site of disease in the peritoneal cavity, who really should benefit from cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. We know that abdominal carcinomatosis is no question associated with marked deterioration in quality of life because of the potential for bowel obstruction, inability to eat, difficult to sleep, and the patients with abdominal carcinomatosis who fail chemotherapy or are not treated have very limited survival. We also know that systemic chemotherapy is not very effective and has not altered the natural history of peritoneal carcinomatosis simply because there is no effective way of delivering the chemotherapy to these carcinomatosis for it to be effective. Malignant ascites, bowel obstruction, and failure to thrive are the most common reason for failure of this therapy. We know with peritoneal carcinomatosis, median survival of stage 4 rectal cancer is reduced to about 6.7 months versus 18 months when carcinomatosis is absent. So you can tell that abdominal carcinomatosis have a very poor prognosis. If you look at treatment with systemic chemotherapy in advanced or metastatic colorectal carcinoma, certainly we have made great advances in chemotherapeutic agents, and you can see that with the new chemotherapeutic and as well as the biological therapy, that the median overall survival is now somewhere between 20 to 24 months. With addition of biological agents, you can certainly get a few months added to that, but nevertheless, the disease progression-free survival has not significantly changed with the advancement in therapy. Now, if you look at peritoneal carcinomatosis and colorectal cancer and outcomes, if you look at overall survival and disease-free survival, you'll find that in this single study of 506 patients who had cytoreductive surgery combined with intraperitoneal chemotherapy, you'll find that the actually overall survival at 3 years was approximately 47%, and in 5 years was 31%. This is a significant improvement in the survival of this patient. Median survival was at 32.4 months. So clearly, cytoreductive surgery and hyperthermic intraperitoneal chemotherapy added great benefit and also improved the quality of life of these patients. In fact, if you look at the 8-year follow-up of a randomized trial where patients were randomized to cytoreductive surgery and hyperthermic intraperitoneal chemotherapy versus systemic chemotherapy, you'll find that in the hyperthermic intraperitoneal chemotherapy arm, the progression-free survival was increased from 7.7 months in the control arm to 12.6 months. So you can see the difference in the median progression-free survival. In fact, if you look at outcomes in patients with peritoneal carcinomatosis, if you look at the disease-specific survival of patients treated for peritoneal carcinomatosis, you'll find that compared to standard treatment with systemic chemotherapy, you'll find that the HIPEC patient had at least additional 10 months of disease-specific survival. When you look at the overall survival of a HIPEC patient, based on the amount of cytoreduction, whether we are able to completely cytoreduce the patient and remove all the cancer cells versus some residual tumor left behind, you can see certainly that as we move into complete cytoreduction, our ability to increase the survival is significantly better, and in 5 years it was about 47% when we were able to perform a complete cytoreduction, which is removing all the tumor that's in the peritoneal cavity followed by systemic chemotherapy. And the most recent data that has been published regarding cytoreductive surgery and hyperthermic intraperitoneal chemotherapy is really to answer what question, is it really an experimental therapy or is it standard of care? When the data was looked at, and this was published in Annals of Surgery in November of 2008, the overall median survival was about 29 months. The 3-year survival rate was 39%, and we know that factors associated with improved survival, well-differentiated tumors, and again, as I stressed out, the completeness of cytoreduction, which again is our ability to completely remove tumor cells at the time of the operation before the intraperitoneal hyperthermic chemotherapy. Now, if you look at pseudomyxoma persinae, which is related to appendiceal carcinoma, this is kind of summary of trials that has been published regarding the outcome. And you can see if you look here at the 5-year survival for these patients, and you can see it's going to range anywhere from 52% to 72%, which is quite remarkable. In fact, one study showed 10-year survival of up to 55%. So clearly, in pseudomyxoma persinae, there is advantage of performing this procedure, cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. In fact, if you look at this is, again, looks at progression-specific survival. This was a study done in about 402 patients and who underwent initial cytoreductive surgery and intraperitoneal chemotherapy. And you can see by the disease progression occurred in 291 patients versus 111 patients who had disease progression. But again, if you look at how many months after the surgery, you will find that, again, at 10 years, still the cumulative overall survival, even for those who had disease progression, was still quite reasonable and quite good. If you look at even if the patient has a recurrence after performing the cytoreductive surgery and hyperthermic intraperitoneal, specifically in appendiceal carcinoma, you'll find that even patients who were able to undergo cytoreductive surgery, as you can see on the left graph here, you'll find that compared to patients who had surgery, repeat cytoreductive surgery, versus the ones who did not have repeat cytoreductive surgery, you can see that patients who had a second operation, a second cytoreductive surgery, were able to have a much longer term survival. Again, this is very similar to the data that I've shown you before, which again illustrates that the benefit of cytoreductive surgery can be reproduced if the tumor has occurred after the initial operation. Now, if you look at the spectrum of morbidity, what are the potential complications? Certainly can vary quite a bit, and you can see they're listed right here. But again, by far, the most common one that we concerned about is always going to be infection, and usually related to either a Foley catheter or a central line that's placed in the patient. Obviously, bleeding and hemorrhage is a common complication. This is what we call grade 3 adverse events. If you look at grade 4 adverse events, which are the significant complications that can occur after the surgery, you'll find the majority is related to the what we call gastrointestinal complication, bowel obstruction, fistula, and a stomatic leak, which again illustrate the significant amount of technical ability that's required in performing this procedure and the potential for complications. And it's also related to the overall patient clinical condition, nutritional status, comorbid condition, which also contributes to this morbidity. But nevertheless, look at the overall morbidity and mortality. Again, it's not different from any other major surgical procedure that we perform for GI malignancy. I think in conclusion, we know that hyperthermic intraperitoneal chemotherapy coupled with cytoreductive surgery has improved overall survival, especially in patients with colorectal malignancy, appendiceal carcinoma, and mesothelioma. Overall morbidity and mortality is very comparable to other major surgical procedures for GI malignancy. The degree of cytoreduction, surgical cytoreduction, is by far the most important factor in achieving long-term survival. And certainly, long-term survival can be seen after resection of all visible implants or organs involved by the tumor, and it's also feasible even if the patient has a recurrence, because it would still have also survival advantage for this patient. If you are interested in seeing an edited version of a hyperthermic intraperitoneal chemotherapy and the extent of surgery, you certainly can log into the website. You can see in your screen. It's www.orlive.com/UMM/videos/HIPEC, and you certainly can welcome to see the video and description of the actual procedure itself. You can get recorded. Certainly will be happy to answer any questions that anybody would have, and if you're interested in learning more about the procedure, or if you have any questions related to peritoneal carcinomatosis, you certainly can contact my office, and we'll be more than happy to review the information you provide, and we certainly can provide consultation for you anytime you want. Thank you very much. Appreciate your listening.